We'll be doing a panel discussion on antibiotic use in the NICU. And we also had a talk by Dr. Jiva Shankar, but I think that won't be happening today, and we can have it in the next session. And the panelists for today are Dr. Abhishek. Dr. Abhishek is DM from PGI Chandigarh. Dr. Abhishek is a senior consultant and director at Ovum Hospital, Bangalore. Dr. Piyush Mittal has also done his DM in neonatology from PGI. He is working as consultant at Amar Hospital, Patiala. Dr. Prateek is a pass out from Lady Hardinge Medical College, and Sir is Associate Professor of Neonatology at Indira Gandhi Institute, Bangalore. I welcome all the panelists, and I'm sure all of you will find today's discussion useful. I request all the panelists to go deep into each topic and question because we have ample time, and as the first talk got cancelled, right? So coming to the first question, what should be the first line antibiotics in an NICU? And can you give some examples of combinations that can be used? So Dr. Piyush, can you please take up this question?
Yeah. Good evening, Sankal, and thank you for the question. So, this is a very common scenario that we come across almost on every neonatologist comes across on a daily basis. That we get a neonate who is sick, and we know that sepsis is whatever may be the diagnosis, but sepsis is almost always one of the key differential diagnoses. And the challenge in neonatal age group as compared to other older age groups is that the signs and symptoms are non-specific. So even the clinical signs and symptoms don't really indicate that which organism it might really be, even if it is sepsis. And the blood cultures that is still the gold standard takes 24 to 48 hours to grow and to give us any targeted indication towards what we should be really trading. So we are really in the dark initially 24 to 48 hours. And so we have to start empirical antibiotics in almost invariably. So how do we make a rational decision in that situation? So the only solution is to use the local data, local antibiogram. There is no substitute, there is no shortcut, and that is the only way to move forward to have a to improve outcomes in case of in neonatal sepsis and to prevent the emergence of multi-drug resistance. So how do we go about it? So it is a stepwise approach. So you need to make a team to make your local antibiogram data. So the team should consist of a clinician, microbiologist, and your hospital pharmacologist as well, right? So the first and foremost step is to collect the local data. Now, what should be the duration? So 6 to 12 months period is considered as an ideal duration for your last culture data regarding the isolates that you have grown bacteria and along with their sensitivity profile, right? So, and this is a statistical requirement that to make a policy regarding antibiotics, to be reasonably sure that this policy would work in your subsequent babies, at least 30 isolates should be there. Right. So to be reasonably certain that this policy would work in reasonable number, like let's say 65-70% of the babies, this would work. So to be reasonably sure, one should have at least ideally 30 isolates. Now one can segregate depending upon the bacteriological profile, whether the early onset and late onset, depending if the particular unit has the organism profile that is different. But as we have seen in most of the data that is published from developing countries, the organism profile in early and late onset sepsis is not that different. So one may formulate a single policy as well. That depends on local hospital to hospital, region to region. So first step is that to collect the data. Next is to create an antibiogram, which is nothing but a frequency table on your Excel sheet where you collate all the data. You enumerate what all organisms and how many organisms have been isolated and against what all antibiotics they are sensitive. So just enter that on an Excel sheet. And then once that is done, because we know for various reasons, we generally tend to start a combination of antibiotics to have synergy and prevent emergence of resistance. So then we create a new cumulative anti-myogram in which accounts for the sensitivity of the individual bacteria to various combinations of antibiotics, various combinations that are rationally otherwise also being used. So we can create that, and then we have a cumulative antibiogram. I'm sorry, I couldn't show a representative table. I couldn't add a slide for that to have better understanding. But anyways, can you go back? So once that is done, so the last step is to choose various lines of antibiotics. Your first line, second line, and third line. That is the last step. So again, these are not hard and fast rules. It may vary from unit to unit, but general broad principles are that your first line antibiotics should cover 70 to 75% of all the isolates. And second line antibiotics should cover 80 to 90% of the isolates, and third line antibiotics should cover about 90 to 100. Basically, all the isolates should be covered by third line antibiotics. Next slide. So these are broad principles of choosing the first line. We want to choose a lower generation of antibiotic, right? This classification has been given by WHO, aware classification, where they give you a broad principles like access, watch, and reserve drugs. So one should, as much as possible, start from the first line, access drugs, again to prevent the emergence of resistance to the higher antibiotics which we want to avoid. So this the lower antibiotic which has the highest possible coverage with minimal side effects, and which the combination which is most economical. So just for reference, these are the commonly used combinations that we use. So one is a beta-lactam antibiotic, and it is generally combined with a aminoglycoside. So if a unit is, for example, a unit which does not cater to very sick neonates, or this incidence of sepsis is not very high, one would assume that the incidence of MDR would also not be very high. So one can go with one might get, as per antibiotic sensitivity, reasonable sensitivity to ampicillin plus gentamicin or amikacin. Or ciprofloxacin amikacin is a combination that is also very frequently used in quite a number of NICUs. And but if there is a resistance, and it's a level 3 NICU, which, as sir just mentioned, that if there is very high prevalence of MDR, so these are just broad guidelines. One may have to go for so-called second line drugs and make them as even first line. For example, cefotaxime, third generation cephalosporin. If there is a very high resistance to your first line, and then if you're not able to get your 65 to 70% coverage with these first line antibiotics, one may have to add cefotaxime in their first line. And even some units today, we would be aware that may be using even carbapenems, if there is such because there is such high resistance. Another point I wanted to add is that third generation cephalosporin can also be considered in first line. Can you let's go to the next slide. Yes. So these are just broad guidelines, as I said initially, that local antibiogram and this policy would be helpful when the signs and symptoms are non-specific. When you're not, the baby's clinical picture is not giving you any clue that which direction to move forward. But still, if there are certain clues, then one may have to tailor your own antibiotic policy as well. For example, if the strong suspicion is of meningitis, then antibiotic with adequate CNS penetration, for example, again, as I mentioned in the previous slide, third generation cephalosporin, or if there is high resistance of third generation cephalosporin, one may even consider adding carbapenem as a first line. And for deep-seated or skin and soft tissue infections, one should along with gram-negative, give gram-positive cover also. And depending on MSSC or MRSA, again, depending on the prevalence in that unit. And in certain situations, for example, life-threatening situations, for example, baby presented with shock and scleroderma or DIC, conditions like that, one may consider on a case-to-case basis, jumping the first line directly to second line. So
Thank you, Dr. Piyush. I think that covers a lot of aspects. One thing is that when we say empirical antibiotics, the word empirical means that an antibiotic which is modifiable by further observation. So first line or empirical antibiotics we generally choose based on the antimicrogram and microbiome that you are getting in the past few months. I think each and every unit has to choose its own combination. Typical combinations like Ciplox plus amikacin, and piperacillin plus amikacin are used as first-line agents, and then the antibiotics may be changed based on the subsequent clinical profile and blood culture reports of the baby. Should we routinely use third-generation cephalosporin as an empirical and first-line agent, Dr. Piyush?
So, yes, as I mentioned, it should not be routinely used, but if your antibiogram, just to these conditions, like your antibiogram suggests that there is high resistance to your first line, your first generation beta-lactam, ampicillin, and other things, they are resistant, then you have no other option but to
Yeah.
add third generation. And secondly, for its CNS penetration, if even if you are using a first generation in your unit as per sensitivity, but if the suspicion for meningitis is strong, you would want to use a third generation to ensure adequate CNS penetration.
Yes, I agree. And so if your microbiome that is suggestive of 2, 3 more and antimicrobials as sensitive as showing 70, 80% sensitivity, I would prefer choosing other antibiotics over third generation
Ab-
cephalosporins,
Absolutely correct.
like because of other reasons, like prolonged use of third generation cephalosporins are associated with selection of ESBL producing organisms. They are associated with fungal sepsis and more dysbiosis as compared to other, and increased chance of NEC. So I would prefer using other drugs as first line agents if my sensitivity allows so. Now, my third question is to Dr. Abhishek. If the child is sick, for example, at the time of receiving the baby, the child is in septic shock, does your empirical or first line choice of antibiotics change? Just to clarify, we are talking about empirical or first line antibiotics here. Our definitive antibiotic will depend on the blood culture report. So if you received a baby, baby is very sick, and the baby, does your first line antibiotic change? And what about a different scenario where the baby is not very sick, but has a very high CRP and procalcitonin? Does your choice of antibiotic change for such a baby?
Thank you, Sankalp. I think the answer for the first question obviously is yes. For a sick baby, we all know the risk of mortality is higher. Typically, we upgrade. Let's say the baby is on first line antibiotics. I've used first line because first line can differ from my unit to your unit. If the baby is already on first line, move to the second line. If let's say the baby is already on second line, move to third line. Basically, you move up the ladder rather than starting direct third line. It depends on other factors as well. So it may not be the rule always. We cannot be rigid. Sometimes you may get an outborn baby who is quite sick, intubated, has multi-organ failure. Probably you may have to start third line directly at onset. It may not be the case in an inborn baby. Or second situation where we move up the ladder is, let's say other baby has similar symptoms in the unit who already has a known organism which is sensitive only to third line. We may directly have to go to third line based on antibiogram data. There the rationale is we already know the antibiogram of the adjacent baby there. So the message there is we upgrade one line ahead whenever the baby is sick, especially shock. But if the baby is outborn or you have other baby in the unit which has similar organism, probably you may have to consider same organism based on sickness.
Agreed.
Next slide. So regarding high CRP or procalcitonin, remember CRP or procalcitonin has more negative predictive value, meaning if they are negative, you are 80 to 90% sure that there is no sepsis. You send these investigations to rule out sepsis, not rule in sepsis. So they are not the diagnostic markers, they're only screening markers. Hope I'm clear with that. Remember, we should treat the baby, not the lab reports. However, keep a low threshold to upgrade. So whenever you have high values, so consider the clinical situation. There can be confounding factors of high lab reports, probably meconium aspiration, where there is inflammatory chemical pneumonitis, which can alter your CRP values. Many a times, procalcitonin in first 72 hours is high, unless you are referring to our specific nomograms of procalcitonin, you may end up falsely treating it. You have a deep-seated abscess, you can have high lab report. It could be a true lab report then. Probably you may have to be cautious with covering for pyogenic organisms. Sometimes even post-surgery, you can have very high CRP or procalcitonin. So whenever you don't have these confounding elements, keep a low threshold to act on these high values of CRP or procalcitonin. Next slide. So when I searched in PubMed, there are at least 4 papers, majority from China. So I do not know the validity of these papers, but in adults, there is a systematic review. But with respect to neonates, procalcitonin, they have shown some value in predicting the severity and prognosis. I know it's a very small sample. This is the only study I could get with large numbers. So in a limited sample of 75 newborns, Zhang and et al. Showed that procalcitonin more than 75 nanogram per ml had higher risk of death. Sensitivity was 80%, specificity of 90%. So the area under curve was 0.88. It had a good, reasonable predictive value. Probably it needs to be tested in larger sample before we can actually start treating this high procalcitonin.
Thank you, sir. So just to summarize that if you have a baby with high CRP and procal, look at other confounding factors which may have increased these values, and don't straight away start with second or third line antibiotics, but keep a low threshold for upgrading.
Probably this is one nomogram which I have placed for people's reference. You can directly get from Chisa et al. Study 2011. So you have separate nomograms, our specific nomograms for term babies, preterm babies. Your x-axis is time in hours, y-axis is microgram per liter, or it is nanogram per ml. Sorry, not DL, it's nanogram per ml. So you can see they're in logarithmic values. You cannot easily compare the y-axis. So what I would say, at 24 hours, it could be as up to 40 as well. We don't know because they are logarithmic y scale. At 48 hours, the values can be close to 10. By 72 hours, anything more than 2 is high in term or preterm babies. 0.5 to 2 is borderline. Make a clinical judgment there. Less than 0.5 is negative. The primary purpose, as I mentioned, is we send procal to look at a negative procal, not to see a positive procal. So thank you, Sankalp.
Thank you, sir. Thank you. I think I think just a summary of this slide is that there is a normal surge in procalcitonin, and which settles by 72 hours of life. So in the first 72 hours of life, take procalcitonin values with a pinch of salt, or use a R-specific nomogram. So my next question is to Dr. Prateek, sir. When do you use reserve antibiotics like colistin and polymyxin in your unit?
In our Sankalp, is it audible?
Yes, sir.
In our unit, we use reserve antibiotics like colistin, especially in a neonate who is already on a second-line antibiotic like meropenem. And if there is a clinical deterioration in that baby, in such scenarios, we add on colistin along with the infusion of carbapenem. In some scenarios, if we have started on first-line antibiotics, whatever is going on in our unit, and if you get a culture report at 48 hours, and if it is showing, and if the baby is not deteriorated, and if it is suggestive of a XDR or carbapenem resistant enterobacteriales or a carbapenem resistant Acinetobacter baumannii, which is sensitive to colistin, in such situations, we add colistin along with the infusion of a carbapenem like meropenem.
Okay. So for our fellows, can you please explain what is XDR, what is MDR? And what is CRE and CRAB? Sir, am I audible? So XDR is extensively resistance. Yes,
Is audible?
yes, you are audible.
Yeah. XDR is extensively resistant extensively drug resistant. CRE is carbapenem resistant enterobacterial. CRAB is carbapenem resistant Acinetobacter baumannii.
Okay. So if the baby is clinically deteriorating despite being on meropenem, then we'll use this reservoir, or if the blood culture is sensitive of any of these organisms. Sir, in which scenario, sir, you consider giving MRSA cover like vancomycin or linezolid to the babies?
Usually the most common indication, where we add vancomycin is if we have sent the blood culture and we get gram-positive cocci, but still we have not got the sensitivity report. In such situations, we add on vancomycin, especially if the baby is very sick. Means we would have got the report from the microbiologist saying that it is a gram-positive cocci, but we don't have the sensitivity pattern. And if the baby is very sick, that is one common scenario where we add on a reserve drug like vancomycin. The other indication is if the baby has clinical features of staph sepsis, like if the baby is having skin peeling, deep-seated abscess, or deep-seated infection like septic arthritis or abscess, especially in the units with a higher rate of MRSA infection. This is another scenario where one can consider adding vancomycin along with gram-negative cover. Other scenario is a well baby who is a well neonate who is having a central line or PICC line for nutrition purpose or just for IV fluids, who develops features of CLABSI. Just to give a gram-positive cover, you can add vancomycin. And in any of the above scenarios, once you get the blood culture report, and if it is showing MSSA, not MRSA, if it is showing MSSA, it is very important that you downgrade the antibiotics to cloxacillin or ampicillin. The reason is that the vancomycin's killing ability is very less with MSSA. The mortality rate will be higher if you give vancomycin, and the efficacy is also not good. So if you get an MSSA, it's very important that you downgrade it.
Yeah, sir. Thank you for this. And I think I totally agree with you that not just for antibiotic stewardship in general, if you as principles of antibiotic stewardship, if the bug is sensitive to a lower antibiotic, you should de-escalate. But in this, the de-escalation will be rather more useful because drugs like cloxacillin are more effective in MSSA than vancomycin and linezolid. So one should definitely de-escalate if the bug is MSSA. And I would just like to add a few more examples of staph sepsis, like a baby who has a nematocele or necrotizing pneumonia or empyema, and bone and soft tissue septic arthritis, osteomyelitis. CLABSI we have covered, and other foreign bodies if they're in situ, like VP shunt. Then a child develops infection who has a meningitis and who has a VP shunt in situ. And in all these scenarios, one should consider adding a staph cover. And if the unit has a higher incidence of MRSA, one should add MRSA cover. So Dr. Abhishek, can you suggest empirical antibiotics for the following common scenarios like early onset and late onset neonatal sepsis? In sepsis, I would request you to cover both with and without meningitis, necrotizing enterocolitis with and without perforation, pneumonia, osteomyelitis, septic arthritis, UTI, skin infections like tonsillitis.
Yeah. I think every unit should have its own protocol. Before making a protocol, let's try to review the evidence. Already, Piyush has made my job a bit easy. So this is a figure from Dennis study, basically Delhi neonatal infection collaboration study, which was done last decade. So if this is a busy figure there, x-axis you have days, y-axis you have the percentages. One in blue is Acinetobacter. One in, I could say, one in second color you can see is Klebsiella, probably one in orange to red. So you can see most important thing is first 3 days. Acinetobacter is the most common organism in probably in that collaboration. If you see, that is early onset sepsis. If you see the second group, day 4 onwards, still Acinetobacter is the king. So what I would like to say here is probably in that group of hospitals, Acinetobacter is the new king. So that's the most common organism. So your EOS, LOS needs to be handling Acinetobacter there. Let's look at a second study called ANISA study. This is not a blood culture based study. This was a PCR based study. So where they involved community based organisms in newborns. In this study, although it is from Southeast Asia, we had 2 major hospitals from India, CMC Vellore, Orissa. So before we actually go into it, I would like to focus on GBS here. So except CMC Vellore, none of them had probably GBS in Orissa. So GBS is of matter of less concern in probably India, I would say. So what this study found was, next, Sankal. So the most common organism they found was amongst the most common was viruses, respiratory syncytial virus, followed by urea plasma species. You had Staphylococcus aureus and E. coli. So probably if I have to say, it is RSV, followed by E. coli, Staphylococcus species, and urea plasma. So our most common organism could be simply RSV only. Put together overall, the most common organism was RSV, followed by urea plasma. And one good thing this study noted was, next, majority of the bugs were sensitive to penicillin, gentamicin, ampicillin, or its combination. Let's say you're sitting in periphery, your ampicillin will definitely work. Aminoglycosides may definitely work. But if you're sitting in a tertiary care NICU, probably gentamicin may still work. That depends on your combination. So next slide. So with this, we were confused. In North India, you have Acinetobacter. Some PCR-based studies says you have viruses as the common, followed by urea plasma. So when you have questions, you need to ultimately find answers. So we formed a collaboration with like-minded people. I think Pratik is also one of it, and we have Suman ma'am as well. So we made a collaboration with 6 like-minded centers from Bangalore. So that is Indira Gandhi Institute, St. John's, 2 centers of Ovam, Chinmaya Mission Hospital, MS Ramaya Medical College. All 6 centers put together, we did a collaboration with support and mentoring from Dr. Gautam Suresh sir. So what we noticed was, we had total 3% sepsis. That is 239 episode of sepsis was there. So in South India, somehow Klebsiella is the king. Klebsiella is the most common bug, followed by cons and E. coli. And similar to what was found in Anisa's study, I would say in our group of 6 hospitals, amikacin monotherapy had the highest sensitivity. If you see early onset, 70% was sensitive. LOS, 60% was sensitive. Ampicillin plus amikacin gave us hardly 3% advantage for EOS, hardly 1% advantage for LOS. Cefotaxime amikacin, no difference. LOS, no difference. Ciprofloxacin amikacin, probably no difference. LOS, no difference. Piptaz and amikacin probably added some more advantage, and for LOS, no difference. So what we learned from our study is, probably amikacin monotherapy is good as a first-line agent for EOS, while Piptaz and amikacin, considering 80% sensitive, what Piyush has already discussed, probably we can choose as a second line, is what we felt in our collaboration. Remember, this collaboration we did for 2 years, because all these units had a very strict quality improvement protocols in infection control. So it was a challenge to get this 239 episode over 2 years in nearly 6,000 plus babies. Next slide. So you must be wondering, typically empirical antibiotics, we need to cover both gram positive, gram negative. So most of us end up using dual antibiotics. But looking at the data, looking at the antibiogram, we are using monotherapy for last 4 years, I would say, and we have not faced any problems. So I'm not saying you to use monotherapy. Again, probably you need to look at your individual unit data. So this table, what Piyush was trying to mention, so your first line antibiotics may be similar to what the first column have mentioned. It could be augmentin, entamycin, or ampi-netilmycin, or augmentin netilmycin, or amikacin like us. So it depends on your unit policy, the sensitivity what you have, what organisms you are seeing. Second line could be any one of them. It could be Piptaz amica, Piptaz ofloxacin if you have aminoglycoside resistance, cefotaxime amikacin if you have more meningitis, cefoperazone sulbactam if you have MDR Klebsiella, Pseudomonas, especially if you are a outbound unit. So meropenem if you have more meningitis. Colistin, I agree with Suman ma'am's chat there. Never use colistin as an empirical antibiotic. Use colistin only if your blood culture is positive. Rarely you may use colistin if the baby deteriorates on meropenem who is already intubated has MDR, you end up adding colistin and avoid using colistin as a monotherapy. Usually you combine Miro with colistin because you have some data from oncologic literature that using colistin alone, you may end up with more resistance. And colistin is a narrow drug. Remember that. It has a narrow therapeutic index. You can add vancomycin with the points discussed already by Pratik. Tigecycline, to be frank with you, we use rarely. So if you're an inborn unit, rarely you may require tigecycline, unless for an outborn unit where you have a XDR there. So linezolid, again, it's a rare situation, especially in outborn setting. So what we use in our unit is have marked in red amikacin first line, piptaz second line for our inborns, cefoperazone sulbactam only in very specific situations. You get a very sick baby from a nearby hospital where you know they grow MDR over the last 5 years. So it's a very rare situation. We use cefoperazone sulbactam. So meropenem as a third line. We do not do cycling because there's very limited evidence. So we need more evidence for doing cycling. Next slide. So if I have to discuss the choices for EOS for inborn, for the last 5 years, we're very sure amikacin works very well in our unit. For an outborn, we don't take a risk because we don't know the sensitivity here. Because outborn population is variable, we end up giving piptaz amikacin for a baby with symptoms. So LOS pneumonia, again it is piptaz amikacin. If there is meningitis, EOS, probably we add cefotaxime. So which is a very rare situation having meningitis in EOS. I think everybody will agree with me. EOS meningitis is probably less than 5%, which is as per even standard textbooks or even our clinical practice. LOS with meningitis, we end up going up to meropenem. So, or based on sensitivity. NEC without perforation, we use our second line drug, that is piptaz amikacin in our unit. With perforation, we end up adding meropenem. So as an anaerobic cover, especially those who require surgery, rarely we give piptaz amikacin metronidazole. For UTI, again, our sensitivity reports over last 5 years, amikacin is still a first line drug, followed by augmentin. So cefotaxime has been a very poor choice for UTI in our unit. For osteomyelitis, whatever organism we are seeing is most commonly we see staphylococcus. Most of them are MRSA. Rarely we see E. coli or Klebsiella. So empiric choice, we use vancomycin, piptaz. Based on sensitivity, again we taper. For omphalitis, we use piptaz and amikacin. Rarely we add vancomycin if there is skin peeling, baby is sick, having shock. So rarely we use vancomycin. So rarely we add anaerobic. It's rare. If there is foul smelling discharge, we add anaerobic cover, which is a rare situation.
I think thank you, sir, for comprehensively covering. And we have got the gist of how to choose it. However, the choices will differ from unit to unit. But I think you have comprehensively covered how to make a good choice for early onset and late onset sepsis and other scenarios also. So coming back to you, Dr. Piyush, what should be the typical duration of antibiotics in the following clinical scenarios? Blood culture positive sepsis, blood culture negative sepsis, meningitis, ventriculitis, osteomyelitis, and deep-seated abscesses.
Okay. So I've just put up a table which shows, I can, it looks like I can finish my answer in one line, like, for culture negative sepsis, the duration is for 5 to 7 days. For positive, it is 14 days. And then as you go down, as the duration goes on increasing, meningitis 21 days. And if it is, these are deep-seated infections like ventriculitis, osteomyelitis, deep-seated abscesses, generally the duration would be around 6 weeks. But I want to add here that it looks simple, but if one should remember that these are very commonly practiced, duration of antibiotics almost all over the country, or one would say all over the world. But one should remember that these are not really evidence-based. These are just, these came into practice and these were adopted and they have been going on as such. If you go back and try to look for literature and any RCTs or any evidence, you won't find any that to back these durations for 14 days or for 21 days. It is just based on this hunch that neonates, it's a high risk group and would require longer duration of therapy just to be sure that the baby is cleared of the infection. So keeping this in mind, there are now there's a growing interest to study whether a reduced duration of antibiotics would it be equivalent or non-inferior, would it have any harmful effects on the baby. So there are some recent very small studies which have studied the duration of antibiotics or like seven in culture negative or in culture positive babies. For example, in culture positive babies who are clinically well, so they have tried to reduce the duration to 7 days. And but they're very small studies which have studied very few numbers, and what they have found is they don't have not found any difference in terms of relapse of the infection if they stopped in antibiotics at the end of 7 days. But they have chosen very carefully the babies who were asymptomatic by the end of 5 to 7 days. Correct. So they had no dilemma or no confusion in their minds. They were clinically well babies, and when if they stopped antibiotics at the end of 7 days, they found that there was no risk of relapse, and rather there was reduced hospitalization duration, obviously. But again, these are very small studies to warrant at this stage change in clinical practice. Another thing I want to add is culture positive sepsis. One may consider a shorter duration of therapy in case of cons sepsis. So most of the literature would suggest even if a baby is well, a 7 days therapy in cons sepsis would be sufficient. And another point is again, as mentioned, there is then growing literature regarding using serial CRP and procalcitonin again to shorten the duration of antibiotics in clinically well babies. So people have found that is using serial CRPs or serial Procal and using CRP less than 10, or as Dr. Abhishek mentioned, using Procal age appropriate nomograms. If generally two values have come less than your cutoff, one may consider stopping antibiotics, and they have not found any adverse effects in terms of relapse. And again, mentioning the major benefit being reduced hospitalization. So yeah, that's about the duration of antibiotics.
Thank you, Dr. Piyush. I think just to summarize that one can consider using and one should consider using shorter courses for culture negative sepsis. However, for culture positive sepsis and other deep-seated infections like meningitis, when the one should as of now follow what is standard of care so as to be medical legally safe also. Yes, there are some studies which are ongoing and challenging this 14-day course for culture positive sepsis. But as of now, the standard of care is this only. And I think all fellows and should stick to this duration only. However, for osteomyelitis and this septic arthritis, some books they mention that initial 3 to 4 weeks could be IV, and last 2 to 3 weeks of the total 6 weeks course could be oral antibiotics. So that is
Yes.
something that is mentioned like in yeah. Do you agree, Dr. Piyush?
Absolutely, absolutely. So once the acute phase is over, once the inflammatory markers are down, and but you still want to complete your 6 weeks course, so one may complete the last a third of the course with oral, because of obvious line issues, and because of obvious mechanical issues, that practical issues that we face in continuing IV. So again, people have done that, and people have achieved good results, and it is recommended to complete the course with oral antibiotics.
For osteomyelitis and for septic
Yeah.
arthritis. But for culture positive sepsis meningitis, the duration should be 14 and 21 days, and the route should be IV for sure.
Yes, it should be IV.
In blood culture negative sepsis, Dr. Pratik, how do you decide the duration of antibiotics and any role of serial CRP procalcitonin in deciding duration? Just a continuation of previous question, sir.
This has already been explained by Dr. Piyush. If the baby is having risk factor for sepsis, one can stop antibiotics at 36 to 48 hours, especially if the culture is sterile, and if the clinical course is not suggestive of sepsis, and if there is any alternative explanation for the symptoms of the patient. In such scenarios, you can well stop the antibiotics at 36 to 48 hours. If the baby is having clinical features of sepsis along with high inflammatory markers like CRP or Procal, you can give antibiotics for around 5 days. And if the baby is having signs of severe sepsis like septic shock, DIC, scleroderma with high CRP or Procal, and if the blood culture is sterile, in such scenarios, you can increase the duration of antibiotics to around 7 to 10 days, even though there is no much evidence for this. But since sometimes the cultures may be sterile in such situations. And as Abhishek already told, the CRP and Procal has a higher negative predictive value. A negative test will give us a confidence of not increasing the duration of antibiotics. And with respect to the use of procalcitonin, there is an evidence from Neopen study where they have done serial procalcitonin and seen that if the procalcitonin test is negative, then you can stop antibiotics in the early onset sepsis.
Yes, sir. I think that's all from the discussion side. We can now take up the comments and questions from the chat box.